Lymphedema is a condition that can affect those that have had any type of breast surgery. The management of lymphedema has seen great improvement in the past few years. Today, we want to educate, dispel some fears surrounding the possible occurrence of lymphedema for those affected by breast cancer, and we're going to bring you some resources for care. I'm speaking today to Dr. Anton Fries, and he will begin by describing the lymphatic system for us. And then we'll take a deeper dive into detection of symptoms and also surgical and non-surgical interventions. We met in person this year at the ASPS, that's the American Society of Plastic Surgeons meeting in Austin in October of 2023. So Dr. Fries is currently the Chief of Plastic Surgery and a faculty surgeon at UT Health in San Antonio. He recently joined the team at PRMA, that's Plastic Reconstructive Microsurgical Associates in San Antonio, and is performing microvascular surgery with the team of surgeons there. He's from the UK originally, and graduating from the University of Cambridge, Dr. Fries served as a surgeon commander in the Royal Navy with combat experience. He went on to specialize further in plastic surgery through international studies and research, holding significant roles at the institutions like Oxford and UT Health San Antonio. He has authored many papers and, in addition to his academic studies and practice, has contributed to humanitarian efforts, providing cleft lip and palate surgeries in the Philippines through Operation Restore Hope. So, Dr. Fries, you have presented at a lot of international conferences and elsewhere. I'm really honored and pleased that you joined the viewers of Deep Sea Foundation today. So thanks for joining me.
Thanks, Terry. It's my pleasure.
Yeah, absolutely. Well, I'd like to start out, if you could, just by giving us a brief overview of the lymphatic system. What is it for?
Thanks, Terry. Yeah, so we think about the arteries and veins, and we all have the sort of understanding of blood flowing around the body, pumped by the heart, and it comes away from the heart, it receives oxygen from the lungs, delivers nutrients, and then returns, and the system sort of repeats itself.
Mm-hmm.
People are less familiar, I think, with the lymphatic circulation, which is actually a very high volume, up to 4 to 7 liters per day of fluid, which actually flows through lymphatic channels, which are much smaller than arteries or veins. And they really pick up the fluid that seeps out, as it were, from gaps between cells and arteries and veins in our bodies that otherwise would accumulate. But of course, this has to be returned to the main circulation, and that occurs in a larger channel that joins a main vein up in the chest or the base of the neck. And so if you imagine that, in the process of getting nutrients from our arteries and veins to our muscles and other organs that require it, clearly there's a passage of fluid between those cells and those structures, and a certain amount of it leaks out, and that is lymph fluid, and it's returned to the main circulation via lymphatic channels, which are very tiny vessels within the body. It differs from the circulation of arteries and veins because there's no heart driving the lymphatic system. Lymphatic vessels actually have their own muscle in their vessel wall. So in some respects, they're almost like your intestines. So actually they peristalse just the way that the intestine moves food along. Lymphatic channels move lymphatic fluid along. And then they have a system of valves, just like veins do. So as the lymphatic fluid moves along, it's prevented from going back. And so it's quite interesting to have this intrinsic pumping mechanism. And when we come to talk about lymphedema itself, part of the problem and the etiology of the disease is that this intrinsic mechanism is damaged by for example, radiation, surgery, or inflammation. that means that these channels themselves cannot pump the fluid along. So whilst an artery and vein will still receive propulsion from the heart, a diseased lymphatic cannot perform its own propulsion.
Wow, that's a great explanation. It makes total sense now why management of the lymphatic system is so important after breast surgery, since it is disrupted. You think of those pipes flowing, I guess, and if you get a pipe cut off in your house or something, then you have to manage that, right? So that was really a great explanation, one that was easy to understand. So let's move on next to who is then at risk for lymphedema, Dr. Fries.
If you imagine from our discussion that how the circulation works, so anything that interrupts or damages the lymph circulation can cause lymphedema. Now, obviously, your pipe analogy surgery, so cutting through lymphatic channels, most commonly as an axillary dissection for lymph node excision in breast cancer, literally removes, divides those channels and prevents the circulation from flowing. And my discussion of the intrinsic pump mechanism of the smooth muscle in the wall of the lymphedema, radiation, whilst it doesn't cut through any of those channels, the radiation damages that smooth muscle, damages that pumping mechanism. So anyone who's had radiation, anyone who's had a lymph node dissection, and even some patients who and I say this only, and I don't mean only, but I mean have had a mastectomy without an axillary dissection, there's some risk even for those patients. Now, the risk, if you imagine, like a sort of bingo, if you have radiation, axillary dissection, mastectomy, then the risk can be relatively high, and that can be up to a third or even 40% of patients. And decreases as the less invasive your treatments. It doesn't go to zero. So even, for example, the sentinel node, and I'm sure your listeners understand what sentinel node is. It's literally moving one single lymph node. There have been reports of, you literally took one node out, but it turned out that was the critical node, and those patients had lymphedema. So, but the risk is very, very much lower. So so it's depending on the treatment you've had, it's somewhere between probably less than 1% for someone who's, and again I say just, but I mean having a sentinel node biopsy versus someone having full axe dissection, mastectomy, radiation. Now, the very interesting thing, of course, is that having said that 30% chance of getting it, 70% of the people who have that incredibly ablative, invasive surgery, radiation, they never get it. Which is wonderful, of course, but why should that be? That's something that isn't fully understood, quite honestly. So and when you meet a patient for the first time, and we go through these treatment protocols, of course we can't tell if they're going to be one of the unlucky third or the lucky 2/3, which is why we'll probably come on to discuss surveillance is so important.
Yeah, well, that just speaks to the uniqueness of each of our bodies. We all respond differently. I mean, I've talked to patients who respond differently to radiation. I was very much not affected by radiation, whereas I have friends who have had it, who've had, pretty severe and massive burns from it. So that makes complete sense and really does speak to the uniqueness of our bodies and how we respond to all different kinds of treatment, when it comes to breast cancer. So then, what are the signs and symptoms that patients should be aware of who have had breast surgery?
The earliest signs are heaviness, swelling from this accumulation of fluid, and really that's the time to start intervening with treatments to prevent progression, because the problem with lymphedema, and again we'll explore this in our conversation, but it is incurable and it is progressive, which means it gets worse over time. And the reason it gets worse over time is because it's a vicious cycle. And so, as I alluded to, we were just discussing the etiology of lymphedema. It's an intrinsic damage to these vessels in the arm, in the breast cancer patient, or the limbs in other patients, other cancer patients. And so the more fluid there is that accumulates, the more inflammation, the more damage to these vessels and their pumping mechanism, which causes more fluid to leak out, causing more damage. And so there is this vicious cycle that develops. And this is why compression and pumps and massage is effective at slowing the progression, because it's reducing this burden of fluid and therefore slowing down the progression of the disease. So, you may start with heaviness, swelling, but eventually skin changes, so the skin starts to thicken, sort of scaly appearance, kind of erythema, so redness. Patients with lymphedema are at risk of infections because part of the system's role is in treating infections. And I believe there's two components to that. I believe there's the damage to the lymphatic system's ability to treat infections, and there's also this sort of stasis of the fluid and the inflammation, which means that the sort of local response to a cut, a simple wound, for example, is impaired. And so, patients with more severe lymphedema will find that they may have like recurrent so-called cellulitis or skin infections associated with their lymphedema. And if you truly, if people type in lymphedema into Google, some pictures, what so-called sort of elephantiasis of, hugely swollen extremities, ulceration. There's a very rare and wish to scaremonger, but there's actually a cancer born of lymphedema, which is lymphangiosarcoma. It's incredibly rare, but that is a sort of end stage component, sequelae of lymphedema, and some patients even have mutations and things as treatment. So there's a real spectrum from mild swelling to really quite disfiguring disease.
Wow. Yeah, so the message I'm getting from you, given what you just said, is that patients need to be extremely aware of this if they've had breast surgery. Not like you said, not to strike fear, but it's this awareness, because as you said, Dr. Fries, catching it early is key. So my next question to you then is, let's say, a patient has her surgery and she's like, oh, I'm feeling some heaviness, or gosh, my rings aren't fitting the same. What do you generally, or what would you generally tell the listeners would they first go to a lymphedema therapist for, a workup with them, or would it be a clinical evaluation with you? What generally happens? I know it can vary, but in generally speaking, what would you say?
Yeah, so it's such a varied, lymphedema care, unfortunately, is very sort of variable around the country, I think. And particularly surgery in particular, but even therapists and truly skilled, certified lymphedema therapists. There are therapists and there are therapists, and actually the truly certified lymphedema therapists are quite rare. And I know this from my patients who come from all over Texas and even outside Texas to see us, and they find it quite challenging. The other group who are really, really key in this are the cancer rehabilitation physicians, and that's a fantastic group, the physical medicine rehabilitation guys. So patients who reach me come through all those sorts of areas. So the rehabilitation guys, the therapists, or they even come directly. And so, a lot of it, unfortunately, depends on a person's geography, because, life is for living, and, somehow the lymphedema, as I say, it's lifelong. There's no cure. It's progressive. You have to find a way that you can fit these things around your one's lifestyle. So the best person may be many states away, but if there's somebody who can help you locally, then it doesn't necessarily. Well, they could be a therapist, a rehabilitation physician, or surgeon, or whatever. And then once you get in that system, it's a multidisciplinary approach. It's there. And there are specific, there are the sort of specific treatments. So things like, therapy, compression, decongestive therapy, massage, pumps, wraps, all those things. Then there are, of course, surgical treatments which are suitable. And then there are so-called, general treatments of the whole body that have improved the lymphatic system. So certain lymphatic diets, weight loss is a really key one. Lymphedema and weight, eventually a lymphatic fluid, the stasis, it turns to fat, fibrosis, and there's a real correlation between obesity and severity of lymphedema, for example. So patients are being encouraged to kind of take a really kind of holistic approach to managing this problem.
Oh, I like this. And this is where the multidisciplinary approach would come in, because then, the referring patients out to a weight loss system, either, in person, online, I would assume.
That's transformative. And, patients who come to see me for surgery and we start to get into this kind of approach and seeing some wonderful results, that go along with that sort of approach to it, as well as any kind of sort of surgery. Yeah. And the surgery is very effective, but it's by no means a magic bullet.
Can you talk to us about that? I mean, what tell us about the specifics of the surgery, because I know what I've heard, and I'll let you flesh this out, but some procedures are done in office and others are done under the microscope. And I personally consider this like super microsurgery, because as you said in the beginning, the lymphatic vessels are smaller than
that's
blood
right.
vessels.
And this is an evolution of microsurgery, and it wasn't really until the very early 2000s that the term super microsurgery was coined. And this was sort of it's the same sort of technique, as it were, but it's actually having the technology and microscopes that are powerful enough, instruments that are fine enough to reliably handle these vessels. Yeah. And even sutures that are fine can be manufactured. So the instruments I use, the forceps are $1,000 each, and they have a tip that is 0.05 millimeters accurate, which is just mind blowing. And when you compare those to what we would use, the normal micro instruments we use for a deep flap, chalk and cheese. Actually, when you compare them together, it's extraordinary, the difference. It's quite impressive. But to speak to the surgery, really, there's kind of three sort of brackets of surgery. There's lymphatic bypass, where we find a remaining channel and we plumb it into a vein so that the lymphatic fluid flows into a vein peripherally instead of going into the tissue. So you're kind of bypassing the blockage, i.e. where the axillary dissection took place or the radiation. And it sounds, you may worry, well, should this lymphatic fluid go into my vein if it's clearing, toxins and things like this? Well, of course, that's where it ends up anyway, in the neck. It ends up in a vein, so it's a perfectly physiological thing to do. Okay. The second is to do a so-called node transfer, and that is to find some healthy lymph nodes from somewhere else in the body and then implant them into an area affected by lymphedema. And then the third thing, and I mentioned it, and this is actually excisional surgery, so literally excising lymphedema, and that can either be through liposuction, which is quite commonly done, and I do that as well. And then some of these very end stage cases where you kind of excise the tissues and skin graft it, and again, if you type that into Google, you'll see some pretty graphic images, and it's not commonly performed, but that's something that is something that sadly is the only way of helping some of the very, very end stage cases.
Yeah, and I always think of this too. It's not a disease. It is it's a what's the word I'm looking for? It's a symptom of having breast surgery. Not for everybody, of course, like we said earlier, but it's a condition. That's the word I was looking for. It's a condition, not a disease, and it's so important to manage it early on. Okay, so let's talk about the last surgery, the most kind of intense surgery you talked about, Dr. Fries. How long do patients notice improvement?
In terms of the bypass, for example. Yeah. So this is great. So I scan the patients in the clinic, and then it's quite a simple thing to do. It takes half an hour. I put a dye injection into the patient's hand, and I use this flashlight device, and we can literally track the progression of the dye up the patient's arm, and that shows us how the lymphatic system flows. And that's actually, whilst it isn't therapeutic, it's physically therapeutic. Patients find that really valuable, and I was about to say therapeutic, because you get a visualization, and some patients have never the concept of it. Oh, there's this third circulation, it's so small I can't see it, etc. And actually, you can see the channels going up the arm, and some you can't because they're more severe. All you can see is this kind of snowstorm, so-called backflow, where the fluid really can't go anywhere. I've even had therapists have joined me. I've even had therapists perform lymphatic massage under the scanner, and they can even, the patient and the therapist can even see how effective the massage is, because the dye moves up the arm as they're massaging them, which I find fascinating, and patients have found, and the therapists as well. So whilst it doesn't make the treatment, whilst doing the scan doesn't improve things, it does sometimes really give patients an understanding, and there's a lot of aha moments when we do these, and it's as I say, it takes 30 minutes. It's quite an involved thing in terms of the time.
You know what it reminds me of? It reminds me of being in a massively busy city. You don't know where the heck you are, and pulling up Google Maps. You're pulling up your Google map and saying, oh, this is where my lymphatic system is. This is the road closures. This is where they're open. That has to be very eye-opening, I would say, for patients.
It really is. It really is, and it's and then that then determines your treatment.
Mm-hmm.
If you can find, if you can see some channels, some road maps, the roads that are open,
Mm-hmm.
then you can use the same technology in the OR under the microscope to find those channels and plumb them into the veins, and that's how the lymphatic fluid will go away. Now, conversely, if we cannot find any, if all you see is this sort of snowstorm of fluid that's not going anywhere, so-called backflow, then obviously you can't find a channel to do your bypass. So then you have to put the nodes in from somewhere else, or if it's truly if there's no fluid at all and you've already got to a stage where it's fibrosis and scar, then you have to, but then the treatment option really is liposuction.
Okay.
So basically, once the kind of the pathway, for patients is, we meet them, we make sure that a proper assessment, make sure this is the lots of things cause limb swelling. So we do a proper history examination, make sure we're on the right tracks, make sure they're getting the therapy, the compression, all the multidisciplinary, the weight control, the diet, everything else. And then I would normally order outpatient MR scan to make sure check if there's a fluid component or not. And another scan, which they have as an outpatient, which is called a lymphoscintigram, which measures the severity of the disease. And then once we've got all that together and we've started to get on top of things, then they come back and we do the ICG scan in the clinic, and then we decide if surgery is appropriate. And that scan will literally say, okay, you'd be suited to a bypass, you'd be suited to a node transfer, or you'd be most suited to having liposuction or excision. And it's great because we do it literally. They're literally sitting with me in the room, and so it's not a question of going off and having a test and going to a clinic appointment or having a letter, or and so and as the scan's in front of us, we can say, well, that's actually that's great. Your scar is going to be literally there, because that's where the existing lymph channel is that I'm going to be able to find. And so it's a nice way of if there is a nice way of introducing someone to surgery, then it's as nice as some, I think.
Well, I think at the end of the day, patients generally want to know. In most instances, patients want to know. It kind of mentally prepares them. So, here's a big question. Because I mentioned earlier, this is a condition, not a disease. How are we doing on insurance coverage for this? Is this, because I know In years past, experimental surgeries, sometimes patients are like, it's not covered. How are we doing on that, Dr. Fries?
That's a great question.
I know it's a
We have,
tough one.
well, I mean, insurance coverage is a movable feast, as you know. Um,
Yes.
but we're definitely making a lot of progress. Interestingly, one of my patients has a very involved advocacy group, and they were involved with an act of Congress being passed last year, so that Medicare will now cover compression garments and some surgeries, which is incredible. So some of my patients, Medicare patients who couldn't get garments from January the 1st, are going to be able to, thanks to a San Antonio resident, which is amazing, and we're
That's awesome.
super proud to be a tiny part of that. So things are definitely improving. That being said, I have to do a certain amount of appeals and peer-to-peer discussions with insurance companies to get some of my cases approved. But I've been very blessed. I've done almost 100 procedures in the last 3 years, and they've basically been covered, which is great. So we only expect that to improve as the evidence for the effectiveness of these surgeries gets more widely published and more widely acknowledged and established.
Well, I'm going to thank you out loud for doing work on that, because we do know insurance is it's a beast sometimes. So thanks so much for working with that advocacy group and for what you're doing to get this covered for patients. Okay, I'm going to throw a question in for you that I didn't put in our email that I sent you earlier, but I know you've kind of addressed it. But so, nobody wants to have an accident, right? Nobody wants to go out in the yard and cut themselves, or be in the kitchen or cut themselves. But accidents happen. So I had this question come across my email here recently. When, I think as breast cancer patients, we become a little hyper vigilant about things like this. And we're seemingly exercising a lot of caution, but I think it's for good reason. Why, when, I guess the better question is not why, but when can we kind of quit worrying about this? Have you had that question asked before? Because somebody just
Yeah,
asked me the other day, and I wanted to address it since I have you here on the
that's a
podcast.
fantastic question, and I don't want to fly in the face of accepted wisdom. The rehabilitation physician I work most closely with, he's very interested in some of this kind of dogma, and he sees many more patients than I do in terms of breast cancer rehabilitation. And that's what we've been taught, and we've been taught, things such as, not even putting a blood pressure cuff on that arm,
I know.
which and actually, and his understanding of the literature and the incidence of these things is actually, it's probably much lower than we think. Now that and of course, people talk, you must never, these cuts, etc. Well, I do surgery on people with lymphedema all the time. I said 100 cases in 3 years. I haven't had a infected wound. Now, obviously, I'm doing it in an OR and etc. and with a scalpel and it's all sterile, obviously. But it's there's a chance of anything getting infected anywhere, let alone a lymphedematous arm, and yet I've never seen it. So I'm thinking to myself, maybe Dr. Fricky's right. Maybe this really is dogma, and maybe people shouldn't be quite so concerned. On the other hand, of course, some of my most severe patients have told me they were completely fine, and one of them cut herself cooking, one had a dog bite, and they associate the onset of their lymphedema is temporarily associated with this trauma, and you can't overlook that. So it is difficult. The time of
Okay,
onset.
here's what I think. I think, again, I'm going to go back to the awareness. We can't be fearful. I guess that's the message I want to give breast cancer patients. We can't be fearful. It's the awareness and knowing it could happen there's people, like you said, who could get, they go out and cut their finger in the kitchen today. I'm like, oh no, no effect, no problem.
Well, I think you're right. Well, I mean, I don't have when we met, I was still in a splint, wasn't I? Because I got my finger infected from getting a thorn in my yard, and I couldn't work for a month. And I mean, I don't have lymphedema, and I had a terrible infection. So what can you do? I was wearing gloves before you asked. So yeah, kind of as I said before, life is for living, and awareness definitely, but fear no. And just to round that off, certainly, and we talk about screening and using the ICG scanner to screen people, and certainly if you read the textbook, it says that the most cases come on within the first 2 years.
Mm-hmm.
People suggest screening every 6 months, the first 2 years, something like that. Maybe that's quite intensive, but that's something people have proposed doing. And then after 2 years, probably got a clean bill of health. But again, I've had patients who developed it after 9 years, and again, I've treated a lot of patients, but I definitely don't have a truly kind of encompassing view. But anecdotally, from my practice, some of my most severe patients have been the delayed onset, and that may be complete coincidence, but so I think you're right. Awareness, but definitely not being fearful, because these things can happen to literally anybody, as I discovered. I'll go back to asking you a question. I didn't answer it. I'm very sorry, because I went on about something else. But you asked me about how soon do people notice results from lymphedema.
Mm-hmm.
And that's a great question. And like all doctors, I'll say it depends. But actually sooner than you think. When we started down this road, we talked about, you have to lay off the compression for a bit because of the not damaging the surgery. And so it's on a rebound, even they may even get worse because there's no swelling, no compression. And, we were concerned about that. But then patients came back and said, actually, it's much better. And some patients notice a difference, within the first few weeks. I've even had one patient, and she's one of my star patients, so I won't want to advertise this to everyone's expectation, but she still had the sutures in and she put her rings back on when she came back to have her stitches out, and that's at 2 weeks. And that was definitely one of my best, and I wouldn't want to promise that to everybody. But we certainly had some you certainly see some early results, particularly from the bypasses. I think they have because you can see this fluid, and kind of as I mentioned at the beginning, 4 to 7 liters is a lot of fluid. Imagine how much volume that is. I know, sorry, it's not metric, it is metric, but I mean that's was it about 2 pints in a liter? So that's what 8 to 14 liters of.
Don't ask me to convert it. You'll do a better job than I.
But it's a lot. So if you imagine that was getting stuck in someone's arm, and now you've got it to flow away, actually, you might expect some early improvement, and we do see it. The node transfer is a little bit longer. It's a bigger surgery, but again, some of my patients at the 3 and 6 month point have a really, really noticeable improvement that they're really pleased with. So and again, I have a few superstars who come out of compression, even including node transfer patients. I wouldn't want to promise that to everybody, but supposedly 80% of people will have an improvement, whatever that looks like, whether it's reduced heaviness, reduced need for compression, symptomatic improvement with these sorts of procedures. So I tell people that you'll most likely get an improvement, whether it's out of compression, probably not, but possibly, but an improvement then almost certainly. So.
Well, this is what I've liked about our conversation today, Dr. Fries. You answered all my questions, first of all, so thank you. But I really appreciate your transparency. You talked about best case scenarios, worst case scenarios, and you gave very, I think, very realistic expectations for patients who are listening to know there's variations in, how this turns out for different patients. So I really appreciate that transparency. When we get offline here, I think I'm going to ask you, and we will provide in the show notes for, at least for the podcast, this will be on our YouTube channel as well. But in the show notes for the podcast, I'm going to provide some resources for patients that they can link to, and I'll get those from you when we're offline. But again, thanks for joining me today and for this thorough discussion about not only the lymphatic system, but who is affected after breast surgery and what can be done. You covered all the bases, so thanks so much.
My pleasure, Terry. Thanks for inviting me.
Absolutely.